Great. Thank you so much. Really a pleasure to get to visit you, particularly in the depths of winter. I appreciate the invitation. I'm going to give you a slightly different grand rounds today from, I know you've had other kind of book speakers, but I'm going to be telling you sort of a bit of history of specialty of critical care and a little bit about anesthesiology. But I promise that for anyone who does clinical work, I will be ending this talk with a kind of not clinical advice, but something that's relevant to you clinically, whether or not you do intensive care. And I think that's important because I want this to be a talk that is useful and informative to everybody, whether or not this is your specialty. As mentioned, I have a book that I wrote and I have research funding from a number of organizations that are sort of irrelevant to this particular talk. So I'm going to start out with a quote by a cardiologist, Eugene Braunwald. As an intern in 1952, we admitted patients with heart attacks wherever bed was available on the medical service, but always as far from the nurse's station as possible so they would not be disturbed by the commotion, especially the frequent telephone ringing. It was not uncommon for me when arriving on the medical floor at 6 a.m. to draw blood to be sent for testing to discover that one of my patients had died quietly during the night. Older physicians accepted this as just the way it was, right? So 1952, right? I mean, some of you may have been around then, but certainly parents and grandparents were around then, and just kind of thinking about the fact that this was the state of medical care at that time. So it turns out humans love what I call origin stories. Marvel Comics figured this out quite a while ago. They gave us stories like, how did this guy turn into Captain America? And so, I think the origin story that I became interested in was this one, the question of how did we get from ward care that looked like this to modern intensive care that looks like this, and with, the sort of centerpiece really being mechanical ventilation. And of course, it turns out this is 100 years of slow evolution and experiments and changes, but it also turns out that there is kind of one key moment that really kind of catapulted things forward. And that's really the story that I want to share with you today. Now, in thinking particularly about ventilation as sort of the centerpiece of this, the issue is, when and how did people start thinking about ventilation? And I'm going to condense down into one slide, a couple hundred years of experimentation in both positive and negative pressure ventilation. People tried it. They tried it in all kinds of different forms. Why did it not stick in any form? Well, probably some combination of sort of not being in the right place at the right time, not having great access to kind of disseminating ideas easily, and then also just not having quite the technology available to make it stick either. And also a lack of understanding about respiratory physiology, which will come into play in a little bit. But I think it's also important to understand what were the motivating factors for why people wanted to provide ventilation. And as soon as I say, why would you want to ventilate someone? Most people will say pneumonia, right? Like that's kind of the thing that will jump into most people's heads. But it turned out that one of the driving features of interest was workplace accidents, particularly electrocution, gas poisoning, and drowning that happened, and the idea of finding a way to resuscitate people so that they would breathe again. But that said, of course, there was also a lot of interest for people starting to do surgery and more complicated surgeries, general surgery, but in particular thoracic surgery, which was basically impossible to do, right? Because as soon as you open the pleural space, you'd collapse the lung and the person would no longer be breathing on their own. And then in terms of illnesses that were of interest to people, it really wasn't pneumonia. The idea that you might die of pneumonia and that you might somehow help someone to breathe who was struggling to breathe through pneumonia, that wasn't really on people's radar. But what was polio, which was a disease that had sort of started to become much more evident at the start of the 20th century and was causing all kinds of problems. Now, polio has unfortunately been in the news recently, kind of shocking to me when I started writing this book. Nobody was talking about polio, and there it is in the headlines. But I had to educate myself a lot about polio, never having learned about it in medical school. So just a quick primer. Polio is an enterovirus. It's oral fecal transmission. It's actually a lot like COVID-19 in that the majority of people who are exposed to it have no symptoms. They just get exposed, get antibodies, pass it on. For those who did get symptoms, again, like COVID, it was sort of a lot of non-specific symptoms of cold, flu, childhood illnesses there on the left. But then, of course, there was a small percentage of people who got paralytic polio. And so you saw images like this on the right. That's from the March of Dimes, which is the fundraising arm for the National Foundation for Infantile Paralysis, which was one of its other names. And they had a lot of photos, and people would describe being in school, children coming in with arms and legs that were now paralyzed. And what would happen is the virus would leave the gut, go into the bloodstream, and attack the nerves in the spinal cord that mostly controlled, they were the motor neurons, and controlled movement of arms and legs. And so people would become paralyzed from that. However, the virus could also attack the muscles of respiration. And so you could get paralytic polio that was respiratory paralysis. And there were two forms of this. One was that it just attacked the nerves in the spinal cord, and so it affected the muscles in the chest wall. They couldn't take a breath. The other was the bulbar form of polio. And in that, it would attack the brainstem. And so people couldn't swallow, couldn't cough, couldn't clear their secretions, and literally drowned in their own secretions. This was obviously almost universally fatal if you got a respiratory form of paralysis, because as I just described, nobody had a way to help you to breathe. And this changed in 1928. 1928, Professor Philip Drinker was a professor at Harvard School of Public Health, and he actually had been tasked by a company to help with this issue of resuscitation. And he passed by a colleague of his, Louis Agassiz Shaw Jr., who was doing experiments on a cat. And that is a cat in that photo there, if you look closely. And Louis Agassiz Shaw was interested in many things about respiration, but in particular, he was interested in whether or not mammals could breathe through their skin. So he had enclosed this cat in this box. He paralyzed the cat, and he was actually using that syringe, that plunger, to measure the size of the breath the cat took by kind of pulling the air out of the box. But in so doing, he was then also taking samples from the box itself to see whether or not there was evidence of ventilation through the skin and changes in the gas in there. And he published actually in 1928 a paper that said mammals do not breathe through their skin. So it's only 100 years ago that we as humans figured this out. But more importantly, Philip Drinker walked by and saw these experiments being done and the kind of measurements of the tidal volume. And he realized that this motion, this plunger of sucking air out of that box and inflating the lungs, and then pushing the air back in, was actually keeping this cat alive. And he then, in conjunction with Louis Agassiz Shaw, did this for 12 hours straight to demonstrate that they could keep this cat alive that was paralyzed. And he recognized that he could turn this into a human form, and obviously humanized it with a giant version. And this is a picture of the original iron lung. He pulled a motor out of a vacuum in the closet to attach it so that he would have a way to suck the air out and push it back in that was motorized rather than obviously using a plunger. And they tried it on a little girl, Bertha Richard, who was 8 years old, who was dying of polio in Boston Children's Hospital in 1928. And they kept her alive for 5 days. She did ultimately die, but interestingly, despite her death, they felt that this was a great success and that this was proof that this technique would work. And from there, you get this explosion in use of iron lungs for the care of individuals with polio. Now, this is probably the version you're used to seeing, something that looks like this. Those literally are portholes that they welded onto the side. They went down to the docks in Boston, bought some portholes because they realized they needed some way to keep the seal on the negative pressure ventilation while it was happening, but allow nurses and others to get into the patient. So as you might imagine, nurses hated this, right? It was sort of really hard to take care of people in the iron lung, but it was incredibly successful for the spinal form of respiratory paralysis, where it was a question of paralyzed muscles of respiration. It was incredibly unsuccessful for paralysis from bulbar polio, because as you might imagine, you have an unprotected airway, you would just suck secretions down to the lungs and they died of pneumonia, which is actually ultimately what happened to Bertha Richard. And the other thing to know about it is that it really proliferated mostly across the United States because they were also incredibly expensive and they were incredibly heavy to move around. But it really changed the face of ventilation in this country, and really was the first time, 1928, that we had a machine that could keep someone alive who had organ failure. So that truly is the start of that relationship between humans and machines. Now, during this time period, there was, of course, as I mentioned, also interest in helping people to breathe when they're getting operations, because a lot of them, up until into the early part of the 20th century, you had to keep someone breathing. You'd give them chloroform or ether, but fundamentally they would keep them breathing. And then they started to realize they could use positive pressure ventilation with a mask. But this man, Paul Frankner, was an ENT surgeon in Sweden, and he developed in the 1920s one of the earliest positive pressure ventilators, the spiral pulsator. And he started using this on surgeries there. And the Swedes became known a little bit for this. Now, fast forward to World War II, and this is a map of Europe, and the red is all of the countries that were occupied by the Nazis in the war. And you will see Sweden is in white. It was neutral and was not occupied. And there was the very first professor of anesthesiology in all of Europe. And so just again, pause, 1940s, right? To think how young this specialty is, that 1940s, this is the first man in Europe who's a professor, Torsten Gård. And so he became an expert in the spiral pulsator. Down in Denmark was the first anesthesiologist in all of Denmark, Ernst Triermorch. And he was interested in learning from Gård about anesthesia in general and the spiral pulsator. He actually had to get permission from the Nazis in the middle of the war to cross this border between Denmark and Sweden. And he was able to travel into Stockholm, learn from Gård, learned about the spiral pulsator, was not allowed to take one back with him, but took the knowledge of this concept of a ventilator back with him and built his own version back in Denmark during World War II. However, 1949, he has a bit of a fight with the surgeons in Copenhagen, gets offered a job in the United States, and moves to the US. Hold that thought because it will become relevant later on in the story. So by 1952, which is the year I'm interested in, you've got two things happening. On the left there is sort of the development in Sweden and actually in the UK and the US in tiny pockets in operating rooms, some early positive pressure ventilators. I always think that looks like something out of Willy Wonka's chocolate factory, but that is an early ventilator. And then over on the right there, you have the development of negative pressure ventilation specifically for the care of polio patients. That is obviously really helpful in certain forms of polio, but not in others. And the two, there's no crosstalk here, right? These two things are happening pretty much completely separately. So that takes us to the Blydam Hospital, which is this hospital here in Copenhagen. And they were the infectious disease hospital for the entire city. And in fact, to be honest, really most of the country, because it's such a small country. And they saw everything from the 1870s onward. They saw diphtheria, meningitis, smallpox, you name it, they saw it, including polio. And to care for polio patients there, I mentioned that the US had a ton of iron lungs. They had one. And they also had 6 what they called cuirass respirators, which is kind of like this mini iron lung that's strapped over the chest and would suck air, suck the chest open as best it could. You can imagine useful in really mild forms of paralysis, but not so useful for much else. And then this is the one I find extraordinary. They had what they called rocking beds, where they would tie people's feet in and literally use gravity to move the diaphragm up and down to assist in breathing. And apparently, again, for mild paralysis was relatively useful. And people describe being able to sleep while this was going on, which I find extraordinary. But they did have some of these beds. But as you can see, only very modestly equipped. The head of the hospital there was a man named Henry Kai Alexander Lawson, HCA Lawson. And he was this kind of imperious figure, kind of a central figure in Copenhagen medical care. And he was considered a world expert on polio. He'd seen many, many cases over the years. And in fact, in 1951, he had been one of the hosts of the World Polio Congress that had happened in Copenhagen that year. And everybody came, Salk and Sabin from the United States, O'Connor, everybody who was big in research was there, as well as clinicians. And they had this big meeting and he was the host. But as I mentioned, they'd never really had a major epidemic of polio. He'd just seen a lot of cases accumulated over the years. That changed in July and August of 1952 when this started to happen. More than 50 cases a day, 10 to 12 with respiratory failure. And the majority of those cases were bulbar failure, not the standard spinal paralysis. And they were at their wits' end. Why? Because in the United States, polio was the summer plague. It peaked in July and August and then just disappeared on its own naturally. In the Scandinavian countries further north, nobody fully understands why epidemiologically this happened, but it was a disease that peaked in the autumn. Hence the title of my book, The Autumn Ghost. So they knew by mid-August 1952 that they weren't even close to the start of the epidemic. Now, in Copenhagen, at the city archives, is this giant black book that was plunked down in front of me when I was doing research. And as I flipped through it, I discovered that it was actually their book logging every death in the hospital in that year. And January and February, it's, diphtheria and meningitis and a little of this, a little of that. And then you get to July and August, it's just polio, polio, polio. So by mid-August, they'd lost 27 out of the 31 patients who had respiratory paralysis, which is pretty much the dead on 90% that was kind of standard for bulbar polio. And although they didn't understand why, they knew that more iron lungs wouldn't help. They'd tried iron lungs in patients with bulbar polio and knew that it was not successful. But interestingly, they couldn't really articulate what the problem was. So they knew that wasn't the answer, just to get more iron lungs, which they couldn't honestly have gotten anyway. But they didn't know what was. And there was a young doctor there by the name of Mogens Bjornbo, and apologies to any Danish speakers. It sounds like this mush if you say it in Danish. And he was a young doctor still in training, kind of a senior fellow, very well respected by Henry Lassen. He actually lived on the grounds of the hospital with his wife and small children. And he started badgering his boss to invite in this other young doctor he'd met a few months earlier. Now, we don't know whether he had any idea what he might do for them, but he was impressed by his interaction. And there's a whole backstory to their meeting and why he was impressed by him. But the man he wanted to bring in was this man, Dr. Bjorn Ibsen, who was a young anesthesiologist in the city. He'd started out training in surgery, he'd become interested in the concept of anesthesia. He had met Ernst Trier Morch before he moved to the United States, who had said, if you want to learn anesthesia, you have to leave Denmark because basically I'm the only anesthesiologist in the country. Go west. And so Bjorn Ibsen did. He went to Mass General and spent a year there in 1949 working under Henry Beecher. And he learned anesthesia. But he also felt like he learned a lot about sort of different thinking in medicine. And these are some of the quotes he wrote later. At conferences, the young American doctors expressed themselves freely and without inhibitions. I began to understand here that I was among doctors who thought differently and along other lines than those I was familiar with. Initially, he thought there were more complications from surgery and anesthesia at Mass General than he was used to seeing. But then he realized, no, they were actually just trying to learn from those complications. So they actually talked about them. They didn't just sweep them under the carpet. I also find this a little bit ironic because if you ask me to describe Mass General Hospital in the late 1940s, like the word that would come to mind would be hierarchical. And, the idea that it was this kind of open, free exchange of ideas and this different kind of warm, nurturing environment, it would not be my version. But I think it tells you, therefore, just how bad it was in Europe and just how hierarchical it must have been that this was a breath of fresh air to him. So Lassen was not excited. Ibsen was one of 5 anesthesiologists in all of Copenhagen. It had just become a specialty the year before. He was young. He had no fixed job at any of the hospitals. He literally went around hospital to hospital providing anesthesia where he was needed. And in the hierarchical world of Denmark, that was a nobody. But having nothing else to try, he relented. And on August 25th, 1952, he invited Ibsen to his office that morning. And Ibsen came with about 20 other people in the room. And Lassen asked Ibsen, what do you know about the care of polio patients? And Ibsen, being honest, answered that he had never taken care of a polio patient in his life. So I think Lassen deserves a lot of credit at this moment. I think there's many, many people who would have just kicked him out and said, you can't possibly have anything to offer, then, you're wasting our time. Instead, he said, I'm going to take you on a tour of the hospital. I'm going to show you what these patients look like. As they toured, Ibsen noticed this constellation of symptoms: hypertension, tachycardia, twitching, confusion, and clammy skin. And he asked Lassen, what is this? What's going on? And Lassen's response was, this is end-stage polio. The virus has gotten into the brain. It's attacked the kidneys. The body's shutting down. This is irreversible. This is what it looks like. Now, Ibsen looked at those same symptoms and he said, actually, I think this is reversible. I think this is carbon dioxide retention causing these symptoms. Now, that sounds so obvious to us, right? Someone's not breathing. Guess what happens? They, they retain carbon dioxide. But I think, and so it's very hard actually to go back into that mindset to recognize they didn't understand that concept, the doctors at the bedside. There were physiologists out there who knew enough about respiration, but the doctors at the bedside did not. And in fact, it wasn't a given that even as an anesthesiologist that Ibsen would, except they happened to, in a strange coincidence, tapped the one man who was doing studies on end-tidal carbon dioxide using this machine that very year. He took this into the operating room with him, and he would sit there and he would bag his patients down and watch the tracing drop, and then he would stop breathing for them, watch the tracing come back up once he started bagging them again. And he noticed that the symptoms they had when he stopped breathing for them were very similar to these polio patients. That same year, he published a paper on this topic, and makes you wish you go back and do research in the 1950s. They literally took healthy volunteers and show the tracings, and then they go into the operating room and they take patients under anesthesia and they show the tracings. That was the paper essentially, but he understood this concept of carbon dioxide retention. So what did Ibsen propose, having seen this? He said, well, you need to do a tracheostomy on these patients to protect their airway. And Lassen had tried that, right? They had tried giving these patients trachs without much success. Why? Because as Ibsen pointed out, you also have to breathe for them. And so he suggested doing positive pressure ventilation on these patients, as he did every day in the operating room. And again, I think it's that moment where you think, well, it's so obvious. Of course, if you're helping people to breathe in the operating room this way, why wouldn't you just use it on other people? It wasn't done. And there was some, there's that mental block that looks crazy in retrospect, but it really wasn't done, except that Ibsen knew it had been tried. And he had stumbled across this obscure paper in the Annals of Western Medicine and Surgery. A journal existed for 5 years, published in the US. And he had actually had a copy with him when he went to meet with Lassen. And it was about the care and treatment of polio patients in an epidemic in 1949 in Los Angeles. And Albert Bauer and V. Ray Bennett had been faced with basically the same situation they had in Copenhagen, where they had a high mortality with bulbar polio. They actually had a lot of iron lungs, so that was the one difference. But they, as mentioned, of course, with an unprotected airway, they were seeing the same problem. And so what had they done? V. Ray Bennett had done work in World War II. He was an engineer, and he had worked on pilots and breathing at high altitude. So he knew a lot about sort of one-way valves and things. And he created what was called the Bennett positive pressure respirator attachment. And if you look closely, you always can't see the trach, but you can see he's got a tube attached to a trach. And importantly, though, there's also an iron lung here. So this was a combination of negative and positive pressure ventilation synced up. And they reported that they'd reduced the mortality from 90% to 20% in this epidemic. Crucially, Ibsen read this paper and recognized that you didn't need the negative pressure component if you had the positive pressure. And so he was confident that just the positive pressure alone would be enough. And he proposed just the use of what they used essentially in the operating room, which was the waters to and fro circuit, a very simple circuit of a bag, soda lime to scavenge the carbon dioxide, oxygen tank, and a cuff tube of some sort, in this case, a tracheostomy. So Lassen heard this proposal and apparently was not super excited, not really convinced, but with nothing else to try, told Ibsen that he would allow him to demonstrate this proposed technique on one patient only, and that he would choose that patient. The very next day, August 26, 1952, a little girl by the name of Vivi Ebert was admitted to the hospital. She was 12 years old at the time. She's about 9 here in this photo. And this is the house she lived in Copenhagen with her mother and her grandparents. And she had classic bulbar polio on admission. 90% mortality expected for her based on her admitting symptoms. By the very next morning, August 27th, she was already in extremis. And when Lassen rounded on her, it was very clear she was dying. And so he pointed to her and said, she's the one, we'll try it on. So they brought in Ibsen, they brought in an ENT surgeon, they bundled her mother out of the room. There was no informed consent going on and no IRB, and about 20 people piled in to watch. Ibsen was concerned that if he gave her general anesthesia for the trach, that he might kill her because she was so close to death already. And they had pentothal is what they had at the time. And so he asked the NT surgeon to do it under local anesthesia, which he did, but of course, a little technically challenging. And he got into a little bit of bleeding when he did the trach, and he handed over the care to Ibsen after doing the trach. And we actually have Ibsen's minute-to-minute record of what happened. And with the bleeding in the airway, she went into bronchospasm. And everybody left for lunch. They didn't want to see a little girl die. He was clearly struggling to ventilate her. Lassen tapped him on the back and said, if she's like this when I return, you need to just stop what you're doing and kind of let her go in peace. And so he wrote at 1:17 p.m., now in a situation where we cannot perform ventilation because of her spasms and agitation. He knew he had to break the bronchospasm. And so he took a risk. He writes, we administer pentothal 100 milligrams. And everybody held their breath and her blood pressure held. And he was able to break the bronchospasm and he was able to ventilate her. And 15 minutes later, 1:32 p.m., he wrote, the patient is immediately warm and dry. And she woke up, she was pink. He was able to keep bagging her. He demonstrated what happened when he stopped bagging her. He did sort of some tests. He brought in one of his Brinkmann carbovisors. And when everybody came back from lunch, the word that I hate in the ICU, what I call the M word, miracle, had pretty much occurred, right? They knew this was 100% mortality at that point for this little girl. And here she was awake and alert and stable. So they continued this for another 18 hours or so till the next morning, 3 different doctors handing off, hand ventilating her, showing that they could keep her stable, not just for 15 minutes, but for an extended period of time. And Lassen knew a good thing when he saw it. And he said, right, we're going to do this on everybody who comes in to the hospital with respiratory failure. Only one problem. As I mentioned, Ernst Trier Morch, the one person in all of Denmark who knew anything about positive pressure ventilators, had exited the United States in 1949 and taken all of the knowledge of ventilators with him. There was not a single ventilator in all of Denmark. And so what did they do? They put out a call to the medical students of Copenhagen to come sit at the bedside and hand ventilate these patients 24 hours a day. They came initially, a couple dozen of them, and then hundreds of them. And in the end, over 1,200 medical and dental students came and sat at the bedside of these patients to hand ventilate them. They worked 6 to 8 hour shifts. They would get 10-minute breaks for cigarettes, and they would add about 20 minutes for lunch or dinner. But fundamentally, somebody didn't show up for the next shift, they couldn't leave. These were some of them first-year medical students. A lot of them had never touched a patient before in their life. They were given 5 minutes off in tutorial in how to ventilate somebody and left in a room with the patient. Now, the other thing to know is, of course, these patients were awake for the most part because polio only rarely affects the brain. And so they actually got to know these patients. About half of them were children. And so they became very close. They were entertainers as well as ventilators sitting at the bedside. And a lot of them became very close to the patients that they took care of. I actually got to meet a couple of these medical students from 1952. This is one of them, Ann Holton Jensen. She actually became an anesthesiologist. She was a second-year medical student at the time. Ended up taking almost an entire year out of her studies, but it was an incredibly informative experience for her. And she, in fact, named one of her children after one of the patients she cared for. We also have some film footage, so you can actually see what it looks like. Let's see if I can get that to work. I never had a problem before. Let's see. I'm just going to end show for a second and see. There we go. All right, we'll do it this way just so you can see. Oh no. What has happened? This is terrible. I've given this talk many times without this happening. Should have checked it. Okay, well, I'll just go on. But the point to make is that one of the things to know is that they were true anesthesia bags. They were not ambu bags that they were using. And so they had any kink in the system anywhere, of course, you would lose the airflow and it wouldn't reinflate. Ambu bags were invented a few years later, actually, by a Danish doctor. But this was terrifying, right? Because these students had no idea what they were doing. And so there were all kinds of complications and issues and kind of terrifying moments as, oxygen tanks ran out and all kinds of other things happened. And so that's also detailed in my book of sort of all the kind of troubleshooting they learned to do over the course of this. Okay, so the other thing that they learned was around this question of what was going on in the blood of patients who were dying of polio. And was it acidotic or was it alkalotic? And if you asked anyone who worked at the Lyme Hospital, they would have told you these patients were incredibly alkalotic when they died. Now, why? They couldn't actually measure the pH, so they didn't know that for a fact, but they had one measurement of the blood they could make at the time, and that was what was called the total bicarbonate. And it was measured by what's called the Van Slyke method that had been developed in the 1920s. And it was a machine that could take the blood and make this one measurement. And so they knew that if the bicarbonate was super low, that this was likely a metabolic acidosis. So they just extrapolated when they measured on these patients and the bicarbonate was super high, that they had a metabolic alkalosis. Again, they didn't know about carbon dioxide. And so they didn't recognize that what they were measuring was, in fact, the sum total of the carbon dioxide plus the bicarbonate in the blood. So Ibsen comes along and he says, no. If you could actually measure this, I guarantee you carbon dioxide retention, these patients would in fact be acidotic. There was a man in the room, Dr. Paul Astrup, who said it was like a light bulb went off. He was the head of the laboratory. And he said later in an interview, we just didn't think about carbon dioxide. And he was super excited to test this theory and to determine whether Ibsen was right. But as I mentioned, he didn't have a pH monitor. He had no way to check the pH of the blood. But he realized there was somebody down the road who did. And that was Radiometer AS, a company who developed a pH monitor for the Carlsberg Brewery who wanted to know the pH of their beer. And so the technology existed. It just wasn't used in the care of patients in the hospital. So he brought in one of their machines. They let him borrow it. God only knows, like the idea that now blood was, kind of horrible OSHA, HIPAA, like, oh, I can't even imagine sticking blood into one of these machines. But they did. And they tested it on a little boy who was dying of polio or very close to death. And sure enough, just as Ibsen predicted, and as we all know, the pH was incredibly low. So he recognized that you needed, of course, much more than this one measurement to understand what was going on, that you need to be able to triangulate the carbon dioxide with the bicarbonate, and that, in fact, this was useful information for ventilation because the carbon dioxide would go up and down depending on whether you were ventilating correctly or not. So he develops the first blood gas machine that is used at the bedside for the care of patients in a routine manner. And by the end of this epidemic, they'd done 705 determinations of pH in the arterial or venous blood. Really extraordinary feat when you think about the fact that he was starting kind of from nothing and created this in real time. So their intervention was incredibly successful. We were talking earlier that sort of most things we do might have like a 1 or 2% difference in mortality for people if we're lucky. They went from an 87% mortality down to about a 36% mortality and all the way down to an 11% mortality by the end of the epidemic. Really extraordinary numbers. And of course, they recognized they couldn't use students forever, so they brought in what they literally dubbed mechanical students to take over the care of these patients. First, they brought in a couple ventilators from Sweden that were being used there and they lent them. And then they started to develop their own ventilators in Denmark. And you do start to see this explosion in development very, very quickly within just a few months. Now, I want to acknowledge that embedded in those numbers that you just saw, they're extraordinary. It's an incredible achievement, but that's not a 0% mortality, right? There's still a lot of people in there who were dying. And of course, they were taking care of hundreds of patients. One time they were ventilating 70 patients at a time. And I think it is important to recognize that not all survived. And this became something that was a real struggle, of course, for the people who were caring for them, that you were sitting at a bedside of a 2-year-old who might not make it. And that relationship of literally ventilating them was very, very, very close. One of the students who was there, I didn't get to interview. He died by the time I started working on my book, but someone else who wrote a book about the epidemic, his name is Paul Warwicker, did interview him. And this student described leaving after the mechanical students came in, going back to his studies and trying to kind of function again in society, and describing being in a fog. And I think a lot of people here can probably relate to that after COVID. And he described going on a skiing holiday to try to sort of recover, and skiing alone and feel really kind of alienated, and then sitting at dinner at a communal table. And this is what he said. He said, "I said little during the meal, concentrating on eating. I would occasionally return conversation, but rarely took the lead. As the dessert was served, one of the other guests unexpectedly cracked a bawdy joke. After a momentary embarrassed pause, all in the room roared with laughter, none more so than myself. It seemed that a safety valve had opened, and suddenly I felt able to cast off my reserve. But as I laughed, the tears started to flow, and the laughs slowly changed into cries, heart-wrenching, soulful wails. At first unnoticed, gradually one by one, the diners stopped laughing until the whole table went silent and stared at me, their mouths open. I buried my head in my hands, and at last the cries and mourning and tears for the children came." And I deliberately put this in here for this talk because I feel like it's really important to recognize that as we sort of like celebrate these successes, that we also acknowledge the trauma that goes with that for the people involved. And I think, again, what's extraordinary to me is that this feels so relevant to the same care we've been providing recently, particularly during COVID, for people who are in the ICU day to day. But I think that there's been a lot of difficulty in getting past what happened, and that those words from 70 years ago feel incredibly relevant to us. Now, on a happier note, Lassen recognized the importance of what they'd done, and that he had sort of proof positive of positive pressure ventilation, and he wasted no time in publishing this in early 1953 in The Lancet. For those of you who care about academics, you will note that there was one author on this paper, H.C.A. Lassen. He was not inclined to give credit to anyone else, including Ibsen, for the fact that this idea had come from him. There's one line in the paper that says something along the lines of, "We consulted our anesthetic colleagues." But the important part here, besides the sort of, academic shenanigans, is the fact this got word out in a way that wasn't so easy to do in that time, but everybody read The Lancet. And so people became aware of what had happened at the Lydam, and people started coming to visit and learning more about it so that they could think about using it themselves. Now, Ibsen did not get the job he wanted as the professor of anesthesiology at the University Hospital, the first professorship in anesthesia. Instead, he took the job at the municipal hospital, the community hospital down the street, much less prestigious, but he reflected later in life it was probably the best thing that could have happened. Why? Because if he'd been the new professor at the University Hospital, he would have been spending all his time building up the anesthesia program and providing anesthesia in the ORs. And instead, he kind of was left to his own devices here to do what he wanted. And what he chose to do was to take a vision that he had created to take things one step further from the polio epidemic. And so here in these windows on the second floor of this community hospital, he creates what I consider the first modern intensive care unit. Now, why do I say that? What did he have in his ICU that makes it that? Well, in red is the things he took from the polio epidemic: dedicated area, 24/7 staffing, blood gas analysis, invasive mechanical ventilation, and specialized nursing. He'd experienced the need for all of that in the polio epidemic to care safely for those patients. From his knowledge as an anesthesiologist, he knew about other organ support and resuscitation, and also this idea of very frequent vitals and monitoring that is sort of our modern approach to kind of minute-to-minute care. And then the last piece is that one next step: care for a range of patients. He recognized that what they'd done for the polio patients, they could also do for anybody with respiratory failure of any sort: trauma, post-op, pneumonia, all of those things could potentially gain benefit from this approach. So in December 1953, he takes what sort of starts out as a recovery room and turns it into this modern intensive care unit, admitting his first medical patient from the ward who needs mechanical ventilation. I think it's worth pausing and thinking about what it took to get there. There's obviously a lot of things that we can't and don't want to emulate, obviously a lot of desperation. There's a lot of coincidences. I've mentioned one or two, but there's many more that are sort of detailed in the book. There was a lot of luck, right? What would have happened if pentothal had killed Vivi Ebert, which it very easily could have, given the state she was in. I don't want to say this wouldn't all have happened eventually, but it definitely would have set things back. He was not going to get another chance to demonstrate this technique. And then, for better or worse, lax oversight, probably for worse, but they were able to experiment in a way that, of course, we would not deem acceptable anymore. But I think there's also things that are really important to recognize that we can think about. Exposure to another system of care. And this is really relevant to people who are trainees here, because the American medical system of training is fantastic in many ways, but the one thing it doesn't do is expose you to other systems and cultures of medicine. And so I really always encourage everybody, even if it's just a week or a month, go spend time in another country, see how they provide care, because you will find so much that's the same, but also so much that's different. And it will really help to open your eyes to kind of thinking differently about medicine. Lawson becomes a little bit of a villain there towards the end, but a willingness to break down hierarchy, right? In the moment, he listened to a man who had no standing in medicine in his country, and he was recognized that there was something that could be offered by someone he didn't sort of fundamentally respect at baseline. Ibsen, though, had the courage to speak up and the courage of his convictions that what he knew to be correct about the physiology was correct. And then I do want to acknowledge a financial support to make this happen, that, of course, they needed all the supplies and all the personnel to do this. And they kind of got carte blanche from the city to do whatever they needed to do in the moment to care for these patients. And then I just want to recognize finally that Ibsen really brings an alternative perspective, right? He comes in, he doesn't know anything about polio. He doesn't know about the disease he's being asked to weigh in on. And the important part is he wasn't indoctrinated with the received wisdom of, oh, this is end-stage polio. Oh, this is the virus overwhelming the brain. Oh, there's nothing we can do at this point, right? He was able to see it differently because he hadn't been taught that. And I think this, and is particularly important right now, speaks to the importance of inclusivity and diversity in teams, clinical teams, research teams, administrative teams. You never know who's going to have that perspective and idea that might be the one that's relevant. And obviously, if you think about it, like, well, we're going to convene a team about polio, you wouldn't think to include someone who doesn't know anything about polio patients. And I really think that that's important to hang on to. So 1958, these ideas make it to the United States. Peter Safar in Baltimore, Max Harry Weil in Los Angeles, and Barry Fairley up in Toronto, all that year found what we basically considered the first modern ICUs in North America. We can quibble, there's sort of attempts and pieces of these units that crop up in other places earlier, but they really kind of pulled it all together. And I also want to acknowledge this didn't all come from the polio epidemic. Peter Safar does mention, he says, we knew what they had done at the Blydam, and this really informed the unit we set up. But they were also themselves involved in a lot of work on resuscitation and other things that were obviously very relevant to the care of these patients. And you get an explosion in ventilator development. There are people in the room who may have used some of these early ventilators. And it's really not that big a jump then to what we consider modern intensive care. And really, fundamentally, the care we're providing in our units every day is not that far off the care that Ibsen was providing in that first unit. We've just got some more fancier gizmos and gadgets and monitors. And I do want to think about the future a little bit. And I do actually wonder whether the future may involve negative pressure ventilation again. This is a study back from 2008 that actually used rabbits to demonstrate that actually you get less ventilator-induced lung injury when you use negative pressure ventilation. And so that's a histology score there on the y-axis, and the negative pressure is in the white there. It's really like they were using rabbits, and 100 years ago, they're using cats, right? It's actually very similar research. And I think obviously there's a lot about protecting airways and damage to lungs and things that would mean that negative pressure ventilation is not going to be ideal for many situations in the ICU. But I think there probably are circumstances where it may ultimately be preferable and reduce injury to lungs, just as we've moved a lot more to high flow and away from intubating people as much as possible. So I want to spend the last few minutes talking about the legacy of polio a little bit. If you say polio to people, most people will think vaccines. I hopefully have showed you that ventilators, blood gases, respiratory physiology, and ICUs all come really from the need to care for polio patients, but also other things, rehabilitation medicine. A lot of it comes from the need to help patients with polio get back to full as much function as they can. Disability rights, a lot of the early disability rights advocates for polio survivors, and then long-term sequelae of viruses. And I'm going to come back to this in just a minute. I do want to stop and acknowledge the vaccine. 1955, the vaccine comes out. This is the New York Times headline from that announcement. And, talking to people from that era who were children describe, their parents just breaking down in tears, hearing the news on the radio, seeing the headlines, the relief was just so enormous that they didn't have this worry that their children were going to end up paralyzed anymore. And, I think that it really speaks to the power of a vaccine to really change lives. And if you do need an advertisement for it, this is it. This is in blue polio cases in the US in the 20th century. And you can see after about 1955, it starts to plummet. It's almost zero. There was, of course, a case a few years ago in New York, but basically has been eradicated. And wild type polio, the actual virus that doesn't come from the vaccine itself, that was eradicated in 1979 in the United States. But we are not out of the woods. And I think as everybody who follows the news knows, there is the real potential for people in this room to end up treating a case of polio if we don't keep up herd immunity. And it's pretty terrifying sort of how closely we're teetering now on the brink. I do want to talk about post-polio syndrome for a minute, because this is actually relevant to everybody in terms of interacting with patients and caring for them. It was first reported in 1875, but really it was recognized more in the 1960s and then described best in the 1980s. And it was noted that people who'd had polio, usually as children, were presenting 15, 30, 40, even 50 years later with new onset symptoms, weakness, fatigue, pain, functional loss. And sometimes it was usually it was in a limb or a body part that was affected by paralysis, but it was also sometimes in limbs or body parts that they weren't aware had been affected by paralysis. It's a diagnosis of exclusion. So it's really challenging. And because the symptoms are sort of vague and insidious, it can be hard to diagnose, but it is very clearly a thing. The estimates range from anywhere to 80% to 80% of people who have had polio getting post-polio syndrome in their lifetime. The higher estimate is probably within the cohort of people who had clear paralytic polio when they had the disease. But the lower estimate probably includes a denominator where you have people who maybe didn't know they had a little bit of paralysis as a child, but children compensate so much, they may never have realized that they had weakness in a limb that they just compensated for, or it came back, but they did have some damage. There is a review article from 2000 in JAMA about it. And just to go through quickly what the theory is, so when the motor neuron that controls the muscle gets damaged, we know that in the process of rehabilitation, when people regain function, if they're able to regain some function, they have the remaining motor neurons take over and grow bigger to try to expand and cover those motor units. The thoughts are, one was that this is reactivation of polio. That's never been proven. People have tried to isolate it from people with post-polio syndrome and can't reliably. It could be an autoimmune reaction, but the predominant theory is that this is metabolic fatigue of the remaining motor neuron units. And that just over time that this is happening and that it's sort of irreversible. And so really supportive care is all we can offer. But the reason I say it's relevant maybe to everybody, maybe not the pediatricians or people who do pediatric anesthesia, but for anyone who takes care of older people, to think about, and I've often thought about in the ICU, that patient who seems weaker coming off the ventilator than they should be, or, just kind of more generalized weakness, or coming in for surgery. If they know they've had polio, they're terrified of anesthesia. We actually just have a review article about the anesthetic care of these patients, hopefully coming out soon. We don't have a lot of good data as to what's the best anesthesia and how to provide it, but anecdotally, they are terrified to get anesthesia. They think it will worsen their symptoms. They're worried about prolonged effects and recovery. They're worried about, that even if they didn't have bulbar or respiratory symptoms as a child, that it can kind of unmask some weakness that was there. So just something to be aware of. And I would sort of encourage you, certainly if someone mentions they have polio, to explore that with them and just to be aware of this as a potential diagnosis for some of your older patients. This is a map of Copenhagen from 1952, and this was actually in the back of the photo of Henry Lassen at the beginning of the talk in his office. He sent 6 medical students out into Copenhagen to track every single case of polio that year. And you can see if you zoom in on the city center, it's like absolutely chock full of pins. 1 in 200 boys age 1 to 4 that year in Copenhagen were paralyzed. And each of these different colors is a different month of the year. They were interested in learning more about sort of who was at risk of getting paralytic polio. They didn't actually get much useful data because nobody still really understands that, but it's sort of a remarkable document. And I want to acknowledge these pins are people. And these are some of the people who I got to interview who were polio survivors from 1952. All of them shared their stories with me. All of them are in the book. And the reason I'm biased into saying that I think that the rates of post-polio syndrome are on the high side is every single one of them has post-polio syndrome. The majority of them are now in wheelchairs, even though they were fully functional. Lisa Kay there on the bottom right was a surgeon and had to retire very early because she could no longer physically handle it. But they're sort of an extraordinary bunch of individuals, and I'm very grateful to them. Okay, now I really wanted to end with a video here, and let me try something else here. Let's see what happens if I get out of. Is that going to work? No. All right, let me try one other thing. Sorry, you're going to see all my. I don't know why it's unhappy. No, it must be something about your connection here. Apologies. Yeah, that's frustrating. It's too bad because it's a really extraordinary film, but I will describe to you what it shows, which is that it is, here, let me pull that back up. It's after the epidemic, and it shows them having taken. This is a picture of the Blydam Hospital. And through the gates, it takes you in, and it shows them all in the garden. And it's all the people who are still left on ventilators. And it's extraordinary to me that, ventilators have barely been invented, and yet they're able to get them out of the hospital beds and into the garden attached to ventilators, right? And it sort of, to me, is a sort of message to all of us of sort of like remembering the kind of try to find that humanity. And at the very end, there's an image of a little boy who's walking forward, and you can see he has a trach in place, and it's he's been ventilated at some point. He's now breathing on his own, and his 2 arms are in slings. And he stands there sort of staring at the camera. And he's the little boy who kind of stays with me whenever I think about patient care, because if you look, he's got 2 little sheriff's badges pinned to those slings, and his arms are completely paralyzed. He's unable to move them. And yet, to me, what's the real take home is that someone was trying to make it just a little bit better for him by taking the time to pin those sheriff's badges on him. And so that's my sort of take home clinical vignette, which is, don't forget, ultimately, with all the machinery and all the technology and all the high-tech surgery we do, that it's those little things we do for people that they're going to remember, and that are going to make it just a little bit better in those sort of terrible moments when we often can't do anything for them. So the kind of, bringing people a cup of coffee, getting them another blanket, holding their hand, reassuring them before surgery, taking that extra minute to ask again if they have any questions to try to elicit what their concerns are. That's really, in the end, despite a whole talk about technology and the development of technology, that to me is, I think, the most important message that, that is what really medicine is about. So let's see here. This is the book my talk is based on. And I do want to just to mention the dedication in the front. The second half, it says, for all those who have ever held a life in their hands. And obviously that is every single one of you here in this room and on Zoom. And so really this book is dedicated to all of you. I wrote it for many reasons, but one of them was I wanted us to be able to share with the people in our lives a bit about what it is we do, why they should care, how extraordinary it is, what we can do for people. And so it is very much written for the general public. And so I hope that some of you might share it with your families and friends so they can kind of understand what it is you do all day, every day. Okay, I'm going to stop there. Thank you so much for your attention. Actually, I'll just leave that up. I think we have a couple minutes for questions. All right. Sorry, I didn't leave a lot of time.
If anyone has questions, first from the audience, and then if anyone has questions on Zoom, we can. Oh, sorry, Jim, I didn't see you.
Great talk, Jim Farrer, pediatric anesthesiologist, and anything that touches on pediatrics, I really appreciate, as well as WashU. Go Bears. You speak of how science and specifically then vaccinations altered the course of history, really, and how the trauma for individuals that lived through World War II and then the polio epidemic. We've all dealt with COVID. This will maybe ask you to editorialize a little bit, but we're confronted with, I think, anti-scientific thinking, threats to vaccinations. If you could just comment on how we all stand together to take care of tomorrow's patients.
Yeah. I mean, I guess the basic answer is I wish I had the answer to that, of course. And, and obviously there are people, people like Peter Hotez who are true experts on the sort of anti-science, anti-vax movement. So, I don't have any overall thoughts, comments, statements about how we combat that. But, one thing that has really struck me in thinking about all this is how much we've reached a point of complacency, right? Everybody back in the 1940s and 50s would have gone to school with children in wheelchairs, on crutches. You'd walk down the street, you would see people who had the sequelae of polio. If you go even further back, smallpox, right? You would have seen people pockmarked everywhere on the streets. And that reminder of the power of viruses to cause harm, and not just death, but, kind of these sequelae that would have been daily reminders to people of how scary these diseases were and what could happen to them. We've lived through the last 50 years without that. There's really no other diseases that we have out there that have that same degree where you can actually physically see the consequences in the people around you. And, I know that that's a real problem for people who suffer from long COVID and other diseases like that, where, the frustration where people will say, oh, you look fine, and so I do think, we, for better or worse, have an era where parents expect their children to grow up without dying from measles. They expect them to grow up without ending up paralyzed. And there is a complacency that comes with that. And so one of my big messages is just amplify the voices and the stories that have been lost, because the other thing is polio survivors themselves were very much told, don't talk about it. Put it behind you, move on with your life. Selma Calmes, she was an anesthesiologist in Los Angeles at UCLA. She was in that 1949 epidemic in LA and was in the hospital where they were doing the Bennett positive pressure respirator. She wasn't on a vent, but she told me, I did an interview with her about a 10-minute piece that I put together and showed at IRS 2 years ago. She told me she showed it to her family at Christmas that year. And it was the first time she'd ever spoken to them about having had polio, which to me was just extraordinary, right? That someone, and she had post-polio syndrome. She had the sequelae. So I do think that that's the one thing that we can try to do, is just that reminder of what it is. If you haven't read Roald Dahl's description of the death of his daughter from measles, it's a short piece, but it's absolutely devastating. So that's my only sort of contribution, I think, to that sort of question and cause. And I think, but I do think we all need to fight at this point, right? We can't just go about our day to day and not be doing whatever you can, tweeting, writing editorials, lobbying your Congress people, whatever we can do to try to put pressure to ensure that we don't roll back, kind of care by 100 years.
Wow, thank you. That was a fantastic talk. I'm Daryl Oaks. I'm a cardiac anesthesiologist here. I really appreciate your sort of call to and sort of calling out the importance of having a different perspective on things and keeping our mind open to new ways of thinking, which I think is very hard in a system that is really focused on indoctrination. Like, how do you get people to, sort of function within the system? So I guess two questions. One, what advice do you have around trying to keep our mind open, and how do we balance sort of the organization and standards with sort of keeping our mind open and encouraging different ways of thinking about things? And also where you must be thinking about this a lot as you look through your, sort of lens on your clinical environments. Where do you see opportunities that we should be thinking about?
So, as I said, I think, to be honest, the best thing we can do is send people out into other systems and cultures to experience it. Because I think, a lot of it, unfortunately, comes to your point about indoctrination. People who, to give the extreme, go to undergrad, med school, residency, fellowship, and become an attending all in one institution where there may even only be one hospital, even not, they're not even rotating between other hospitals. Obviously, that's the extreme version. And some of those, I don't want to say those people could be very good doctors, but I think just as a whole, as a kind of organism and system, getting out of that, right? And seeing how differently people can think and care for their patients. And yet it works, right? They often will have better outcomes than maybe we have. And I think that really is the way to kind of open people's minds to being willing to think and consider other kind of ways of doing things. One opportunity where I see it, it's less of an issue, I think, at Stanford than at many institutions, but in critical care where I've worked, the tribalism around what one's background specialty is, right? And this idea that only someone with certain background could truly be the best intensivist. I think that's a huge opportunity for really getting away from that indoctrination, recognizing that everybody's going to have strengths and weaknesses, whatever their background is, because we're not all trained in everything. And that the best intensive care group is going to be one where you're able to trade ideas and use the knowledge and experience of others. And some of that is just integrating, pulmonary and anesthesia, but some of it is saying, someone trained in OBGYN and then does an ICU fellowship, they can be a great intensivist, right? Or they train into some subspecialty that isn't traditionally the path, and being open to that rather than saying that person can't work on our unit because guess what? They haven't had 3 years of putting tubes in people in the operating room and therefore they can't be a great intensivist. And I think there are places, and I obviously this is one of them, where there has been more openness and integration than in many, but that is not the norm in the United States. And I think that we are poorer as a critical care community for it. All right.
Thank you so much. I actually bought this book as we were talking.
Oh, well, thank you.
It's about the World War II piece.
Yes, which I don't get into, but yeah.
Huge fan of, so he's gonna love this.
Yeah, I do have a whole talk about writing the book, and one of the things is the many topics I never dreamed I would need to learn about, and Denmark and the resistance in World War II is one of them, weirdly. So anyway, thank you so much for your attention. Appreciate it.